So next we will be discussing appendages of skin. As I already told you, appendages of skin includes hair, nails and glands. Let us begin with hair follicles. So first we will be discussing hair. If you see the structure of hair follicle, it appears something like this. The tip of the hair follicle is known as ostium. Then there is opening of sebaceous gland. Then there is attachment of erectopili muscle, and there is a bulge area known as Adamson's fringe. So these are four important structures which you need to remember. Tip known as ostium, then there is opening of sebaceous duct, then there is attachment of erectopili muscle, and there is a bulge area known as Adamson's fringe. Among them, Adamson's fringe is very important and already questions have been asked. So remember one important point here, that stem cells are present here, stem cells. So sometimes they ask you that stem cells or reservoir for a stem cell in the hair follicle is, answer is Adamson's fringe, or if Adamson's fringe is not there, just mark bulge area. Okay. Now depending on these four important structures which I told you, you can divide this hair follicle into four parts. Like this is first part, that is ostium, and second, let us consider this is the opening of the sebaceous duct. So this portion which is in between ostium and the opening of the sebaceous duct, this is known as infundibulum. Okay. In between sebaceous duct opening and attachment of erectopili muscle is isthmus portion. In between the attachment of erectopili muscle and the Adamson's fringe is stem portion, and below Adamson's fringe, that is between Adamson's fringe and the base, is the bulb portion. So hair follicle can be divided into four portions, that is infundibulum, isthmus, stem and bulb. Now these first two together forms upper hair follicle and these two together forms lower hair follicle. So infundibulum and isthmus forms upper hair follicle, while stem and bulb forms lower hair follicle. Okay, so if they ask you that upper and hair follicle is the portion of the hair follicle above and below erector pili muscle attachment. Okay, so you can see that above the attachment of this muscle is upper hair follicle and below the attachment of this muscle is lower hair follicle. I already told you the most important is Adamson's fringe, and once this question was asked that Adamson's fringe is component of, and the options were infundibulum, isthmus, stem and bulb, and we all know that it is in between stem and bulb. So which one to choose, stem or bulb? So answer is bulb. Why? Because if you closely see the bulb portion of the hair follicle, let us consider this is the lower dilated bulb portion of the hair follicle, you will find that this inverted V-shaped area, so this inverted V-shaped area is Adamson's fringe. Okay. This was first time discovered by the scientist Adamson when he was studying the patient suffering from tinea capitis. He noticed that this fungal infection, like these spores and the fungal hyphae, they never intruded beyond this point. Why? Because this was the highly keratinogenous part of the hair follicle. So when the cells were infected, it moves ahead and it never intruded, the fungus never intruded beyond this point. So after his name, it is known as Adamson's fringe, and this is the inverted V-shaped area. This is highly keratinogenous portion. The stem cells, the pluripotent cells are also present here. Okay. Now hair follicle have various layers. Like you can see this image, this is the cross section of hair follicle. If you see the cross section, you will find that there is outer cortex and inner medulla. So hair follicle have outer cortex and inner medulla, like you can see here. This is the medulla portion, inner portion. Then there is this outer cortex portion. Then there is cuticle. Now outside cuticle is Huxley layer, then there is Henle layer. These three together, that is cuticle, Huxley and Henle layer, forms the inner root sheath. So there is medulla, cortex, and then inner root sheath. Inner root sheath have cuticle, Huxley and Henle layer. Okay, so once this question was also asked, Henle layer are layers of, the answer was hair follicle. And then there is outer root sheath. So after inner root sheath there is outer root sheath. These are various layers which are present in hair follicle. Among them 4 layers are very important, which you should always remember. These 4 layers are medulla, cortex, Huxley, Henle. If you move outside in, so if you move outside in, you will find that H is common, so E comes first followed by U, C comes first followed by M. So they are following alphabetical order. So if you forget, you can very easily remember that Henle, then Huxley, cortex, then medulla. Next is types of hair follicle. Lanugo hair are seen in fetus. Then villus hair. Then third one is terminal hair. Villus and terminal hair, they have few differentiating feature, like the first one is medulla. This medulla is absent in villus hair while it is present in terminal hair. So villus hair are unmedullated hair while terminal hair are medullated hair. They have medulla. If we talk about melanin which gives color to the hair follicles is absent in villus hair while present in terminal hair. If you look at the depth of these hair follicles, you will find villus hair are present up till dermis while terminal hair are present up till subcutis. These villus hair are seen in pre-pubertal age group while these are seen in adults. So these are few differentiating features between villus hair and terminal hair are the one which are present in adults. We all are adults. We have terminal hair follicles, especially over androgen dependent sites like mustaches, beard, scalp. These are terminal hair follicles. Okay. So we all have terminal hair follicles and our hair follicles are thick, dark and strong. Can you tell me why they are thick, dark and strong? Because they have medulla, they are thick. Because they have melanin, they are dark, and because they are deep up till subcutis, they are strong. While thin, light and weak hair follicles which are seen in prepubertal age group over non-androgenic sites are villus hair follicles. Next is hair cycle. So all these hair follicles, when they grow, they pass through few phases. The first one is anagen phase. This is followed by catagen phase, which is followed by telogen phase. These 3 phases together is known as hair cycle. These are few characteristics of these hair cycles. Phases like anagen phase is the growth phase. It lasts for 3 years and majority of the hair follicles, around 85%, are present in anagen phase. Then catagen is the involution phase. It lasts for 3 weeks and 1% of the hair follicles are present in this phase. Telogen is the resting phase. It lasts for 3 months and around 14% of the hair follicles are present in this phase. Okay. So these are the 3 phases: anagen followed by catagen followed by telogen phase. Okay. So what happens initially, all the hair follicles keep on growing. So this is the growth phase or the anagen phase. It keeps on growing for many years. Average duration is 3 years. Okay. Then there is a transition phase. This is known as involution or catagen phase. And then is the final or the resting phase, which is the telogen phase. And within a period of 3 months, these hair follicles shed off. And when this hair follicle shed off, a new anagen hair follicle come up. Okay. But sometimes what happens, this telogen hair follicle sheds off and a new anagen hair follicle do not come up. So this empty phase, which is sometimes seen, is known as exogen phase. This is seen after hair shedding. So this is not a phase which is regularly seen, but it can be sometimes seen. So this is not included in the phases of hair cycle. So remember, this is an extra phase. So if they ask you how many phases of hair cycle are there, there are 3 phases: anagen, catagen, telogen. But sometimes exogen phase can also be seen. Okay. Now if you find it difficult to remember, you can very easily remember these phases because they are following alphabetical order. So you can remember with ACT: A followed by C followed by T. Okay, so anagen, catagen and telogen. Now sometimes questions are asked on the duration. Okay, so I told you that anagen phase lasts for 3 years catagen phase lasts for 3 weeks and telogen phase lasts for 3 months. So to your surprise, you will find that this also follows alphabetical order. So it is so simple to remember, ACT MWY. Next we will be discussing hair disorders. The first hair disorder is anagen effluvium. Do you know the meaning of this term effluvium? Effluvium means shedding. Okay, so this is what? This is anagen effluvium, that is shedding of anagen hair follicles, and we know anagen are the majority of the hair follicles, 85%. So do you know any condition where most of the hair follicles are gone, 85% of the hair follicles are gone? Which is that condition? Yes, it is seen after chemotherapy. So anagen effluvium is seen after chemotherapy. Okay, so all of you might have seen patients who have undergone chemotherapy. After chemotherapy, they go bald, they lose all the hair follicles. Why? Because this is the hair cycle: anagen followed by catagen followed by telogen. When patient takes chemotherapy, there is arrest in this hair cycle, and all these 85% of the anagen hair follicles, they start shedding off. Now remaining around 14 to 15% are in the telogen phase. Okay, and this is the final phase, this is the resting phase, and this also lead to hair shedding after few months. So these hair follicles are also going to shed off. So how many hair follicles shed off? All the hair follicles shed off. That is what happens after chemotherapy. Patient go bald within few weeks. Second condition is telogen effluvium. Telogen effluvium. This is increased telogen hair loss. This is increased telogen hair loss seen 3 months after pregnancy, typhoid fever, or any chronic illness. So telogen effluvium is increased telogen hair loss seen 3 months after pregnancy, typhoid fever, or any chronic illness. Now this type of hair loss specifically occurs after 3 months. Why after 3 months? Why? Because if you recall, I told you that telogen phase lasts for 3 months. This is telogen effluvium. This occurs after 3 months. Why? Because let us consider this is the normal hair cycle: anagen followed by catagen followed by telogen. 85% of the hair follicles are normally growing, but when patient develops any of this condition, that is pregnancy, any chronic illness, or typhoid fever, what happens? Few of these hair follicles prematurely die, that is prematurely enter into the resting phase. So let us consider, due to these conditions, around 40% of the hair follicles have prematurely entered into the telogen phase. Now once they have entered into the telogen phase, they are not going to shed off at once. They are going to shed off after 3 months, because telogen phase lasts for 3 months. And after 3 months, normally 14 to 15% are lost, but in this patient there will be increased hair loss because all these hair follicles are also in the telogen phase. So this increased hair loss, which occurs specifically after 3 months of these conditions, is known as telogen effluvium. So remember, this is the most important clue in the question. If the patient develops hair loss specifically after 3 months, mark answer as telogen effluvium. Next is androgenetic alopecia. Alopecia means hair loss. So hair loss occurs, and this hair loss is due to, as it is very obvious from the name itself, androgenetic, due to androgens, and there are various genetic predisposing factors. Okay, so this type of hair loss occurs due to effect of androgens and the underlying genetic predisposition. Okay, so there are two factors, genetic as well as androgens. So genetic you cannot change, but androgens are the major culprit which are causing hair loss. Now which androgens? So we know that DHEA, that is dihydroepiandrosterone, gets converted to androstenedione, which gets converted to testosterone, which further gets converted to dihydrotestosterone. Okay, and this dihydrotestosterone is the culprit androgen which is causing androgenetic alopecia. Okay, so this conversion requires various enzymes like 3-beta hydroxy steroid dehydrogenase, then 17-beta hydroxy steroid dehydrogenase, 5-alpha reductase. So in the presence of these enzymes, this DHEA, dihydroepiandrosterone, gets converted into androstenedione, then testosterone, and then dihydrotestosterone. And this, the most potent form of testosterone, is the culprit which causes this hair loss. Now, how these patients clinically present? Clinically, patient presents with patterned hair loss. Patterned hair loss. That is, this alopecia, this hair loss follows a pattern. And these are two common patterns which are seen. One is male pattern and other one is female pattern. Let us consider that this is the scalp of a patient suffering from male pattern androgenetic alopecia. Normally at the time of puberty, his frontal hairline was somewhere here, but with time it has receded backwards and now it is appearing something like this. Along with this, there is also hair loss from this portion, that is the vertex portion of the scalp. So this type of hair loss is known as male pattern androgenetic alopecia, also known as Hamilton pattern. So in this male pattern or Hamilton pattern, two things are happening. First, the frontal hairline is receded backwards and there is hair loss from the vertex portion of the scalp. So this recession is more prominent in this area, that is the temporal area. So this is known as temporal recession of frontal hairline with hair loss from the vertex portion of scalp. So this type of hair loss is known as Hamilton pattern or male pattern of androgenetic alopecia. Okay. Now this is something which is very, very common and most of you sitting here might have experienced this, isn't it? So if you recall, when you were in your school, 6th, 7th, 8th standard, most of the boys, they had a habit of doing like this. Isn't it? Whole day they kept on doing like this, isn't it? Why? Because their frontal hairline was somewhere here and all the hair follicles, they were coming over forehead. So they used to do like this. Okay. But with time, their hairline, frontal hairline reached somewhere here. And now they have lost that habit. Why? Because all the hair follicles are gone now. Okay, the frontal hairline has receded backwards, and along with this they have also noticed a decreased number of hair follicle from this area. Okay, so this is known as Hamilton pattern or male pattern of androgenetic alopecia. Now in females, there are two patterns which are seen. One is known as Olsen pattern, other one is known as Ludwig pattern. In Ludwig pattern, in both the pattern, the frontal hairline is maintained. So this is one very important differentiating feature between male and female. In male, the frontal hairline recedes backwards. In females, it is maintained. So frontal hairline is maintained. But hair loss occurs from this area, that is the frontal and the vertex portion. So if the hair loss occurs from the frontal and the vertex portion, but the frontal hairline is maintained, this is Ludwig pattern. And in Olsen pattern, again the frontal hairline is maintained, but they experience hair loss from this area. That is the site from where the females part their hair, that is hairline. It becomes broad. Okay, so this frontal hairline becomes broad or the hair loss occurs from this area. This is known as Olsen pattern. Okay. So these are two patterns which are seen in females, Olsen and Ludwig pattern, while in males, Hamilton pattern is seen. Okay. Now all this do not occur overnight, okay, isn't it? It gradually occurs, and gradually the hair changes occurs and gradually the hair loss occurs. Okay, so initially you might find few changes like miniature hair. Now what are miniature hair follicles? These are formed due to reduced anagen phase. So I told you anagen phase is the growth phase. So when the growth phase is reduced, what happens? These hair follicles become short. So it is very obvious from the name itself, mini. Mini means short, small. So these are smaller hair follicles which are seen in these areas. One more thing which happens is that the villous hair keep on increasing, and the terminal, that is the thick, dark, strong hairs, they keep on decreasing. Okay, so terminal hair decreases and the villous hair keep on increasing, that is the weak hair and thin hair increases. So here you can see male pattern androgenetic alopecia and female pattern androgenetic alopecia. In male pattern, the frontal hairline was somewhere here, but then temporal recession started. So in the temporal part, the hair follicles are losing and this frontal hairline is receding backwards. Gradually, it has further receded and then complete hair loss might also occur. Here you can see this is the hairline. Gradually, it is becoming broad. The hair loss is occurring, and then this is the portion from where the hair loss has occurred. Similarly, the number of hair follicles gradually keep on reducing. They gradually become miniature hair, that is thin hair follicles and short hair follicles, which are seen in these areas. Like you can see, this is a patient suffering from Hamilton pattern, that is the frontal hairline has receded backwards. So mainly in the temporal part, and the vertex area is also involved. Here again you can see the female pattern hair loss, the broadening of the hairline and loss of hair from the frontal and the vertex portion. Here again you can see androgenetic alopecia. Diagnosis is clinical. What is the treatment? There are various topical and systemic agents which can be used. If we talk about topical agents, commonly we use minoxidil. Minoxidil is, all of you know, vasodilator. It is potassium channel opener, so it increases the vascularity and it also prolongs the anagen phase. Because it prolongs the anagen phase, it reverses the miniaturization. So this is the mechanism of action of minoxidil. The dose of minoxidil which is used is 2% and 5%. 2% minoxidil is generally preferred in females and 5% is recommended for males, though in market 10, 12, 15% are also available. So these are the generally doses which are recommended by US FDA. Remember that minoxidil is US FDA approved. If we talk about systemic agents, we use 5-alpha reductase inhibitors. One of the example is finasteride. Dose of finasteride is 1 mg given once daily. Now remember, I told you for the conversion of testosterone to more potent form of testosterone, we require 5-alpha reductase. So that's why we are giving 5-alpha reductase inhibitors. Okay, so the more potent form is not formed and this condition improves. Now remember that this finasteride is a specific blocker of type 2 5-alpha reductase. So it specifically inhibits type 2 5-alpha reductase. Okay, so this is the specific blocker for the 5-alpha reductase enzyme type 2. But there is one more agent, that is dutasteride, which is not a specific blocker. It inhibits both, that is type 1 and type 2 5-alpha reductase. Okay, so remember finasteride is more specific. It specifically blocks the 5-alpha reductase which is present in pilosebaceous unit, that is type 2 5-alpha reductase. Then another agent which can be used is androgen receptor blockers. Androgen receptor blockers like flutamide. Flutamide is never used as first line therapy. The reason being the side effect associated with it. It is a hepatotoxic drug. Then you can also use anti-androgens. Anti-androgens may cause virilizing side effects. So that's why they are generally not used in males. They can be used in females, like cyproteron, acetate, spironolactone. So finasteride is also not used in females, it can be used in males. While anti-androgens, they are generally used in females, like cyprotron acetate and spironolactone. Now all these were the medical treatment, but sometimes this medical treatment fails or the patient do not respond to it, then you can go ahead with surgical treatment. The surgical treatment for androgenetic alopecia is hair transplant. There are two modalities which are used. There are two procedures which are done for hair transplant. One is FUE and another technique is FUT. So these are the two techniques for hair transplant. One is follicular unit extraction and other one is follicular unit transplant. This is a more preferred technique because in this technique no surgical scar mark is left. So FUE is commonly used, follicular unit extraction. Never question have been asked, so this is not very important, so no need to discuss in detail. Just remember these names, FUE and FUT. These are the two techniques which are used for hair transplant. Next is alopecia areata. So next hair disorder is alopecia areata. Alopecia areata is an autoimmune condition. And in this autoimmune condition, patient clinically present with patchy hair loss. So this hair loss, this alopecia is patchy. That is, you will find patches of hair loss. So let us consider this is your patient. Over the scalp of the patient, you will find these patches. It can be a single patch or you might find multiple patches. Now, if you examine this patch closely, you will find that at the periphery, there are few broken hair follicles, and if you plug them and see them under microscope, they show a very specific sign. So many times this question have been asked. This is known as exclamation mark sign or hair. So exclamation mark sign or hair is seen in alopecia areata. And the important points which you need to remember is, first, it is seen where? At the periphery of the patch. Second, it is a microscopic finding. Okay, so when you examine the patch of hair loss at the periphery, if you get broken hair follicles, plug them, see them under microscope, you will get exclamation mark sign or exclamation mark hair. Let us try to understand what is this. So normally our hair follicles appear something like this. That is, as we are moving upwards, they taper. Okay, but in alopecia areata, you will find such hair follicles which are broken. Their distal portion is broad and the proximal part is thin. So because of this, they are tapering downwards. Instead of tapering upwards, they are tapering downwards. Okay, so this gives resemblance to which mark? Exclamation mark. Okay, so distal portion broad, proximal part thin, and this lower bulb portion looks like a dot. So such hair follicles are seen. These are known as exclamation mark hair. So here you can see this is a patient suffering from alopecia areata. This is the patch of hair loss, and if you closely examine this patch, you will find these few broken hair follicles, and if you plug them and see them under microscope, they appear something like this. That is the distal portion broad, proximal part thin, so it looks like exclamation mark. They appear something like this, exclamation mark hair. This is again a patient of alopecia areata where you will find a patch of complete hair loss. The skin is perfectly normal. There is no inflammation over the skin. There is no redness, no scaling. The only concern of the patient is hair loss. There can be a single patch or you might find multiple such patches. Like you can see, multiple such patches might be present. This is again a patient of alopecia areata where there is hair loss. And this is patchy. Patches are seen. Now along with exclamation mark hair, you should also remember sometimes turning grey phenomena is seen. Turning grey phenomena. turning gray phenomena. Remember one point here, it is due to sparing of gray hair, and second, destruction of melanocytes. Let us try to understand this point. It is due to sparing of gray hair and second, destruction of melanocytes. So sometimes what happens that these patients of alopecia areata come to us and they have these white hair follicles, that is the gray hair follicles in the patch of hair loss. Okay, so what happens, let us consider there is a middle-aged individual who is already having graying of hair follicles. Now he is suffering from alopecia areata. So in this patch what happens, the black hair follicles start falling off but the gray ones are spared, and that's why these gray hairs can be prominently seen. Okay, so patient comes with a complaint of graying of hair follicles, but when you examine you will find that all the black hair follicles are gone, and that's why these gray hair follicles are visible. Okay, so this is due to sparing of the gray hair follicles. But sometimes this graying of the hair follicles can be seen in children also. Okay, so there it was proposed, because this is an autoimmune condition, not only the hair follicles but sometimes the melanocytes are destroyed, and due to destruction of the melanocytes what happens, the black color is lost and they appear gray in color. So remember that sometimes along with loss of hair follicles you might find few gray hair follicles or white hair follicles as well. So this is known as turning gray phenomena. To confirm your diagnosis you can do histology, and on histology you will get perifollicular, especially around the bulb. So this is also known as peribulbal lymphocytic infiltrate giving, so perifollicular or peribulbal lymphocytic infiltrate giving swarm of bees appearance. So swarm of bees appearance is seen, swarm of bees appearance. Let us try to understand this. Let us consider this is that hair follicle of alopecia areata, and around this hair follicle you will find that there is dense lymphocytic infiltrate, and this lymphocytic infiltrate is mainly present around the bulb of the hair follicle. So because this lymphocytic infiltrate is present around the bulb of the hair follicle, that is perifollicular or peribulbal, it appears as if a group of bees is surrounding this bulb. So this is known as swarm of bees, as if a group of bees is present. Okay, so on histology you will get this appearance, that is the perifollicular lymphocytic infiltrate or swarm of bees appearance. Here you can see this is the characteristic swarm of bees appearance on histology, because you have taken the section, the hair follicle is this. So in the center this is the hair follicle, and around hair follicle you can see that all these lymphocytes are present and they are specifically collected around the bulb of the hair follicle. So all this dense lymphocytic infiltrate is seen. If you closely examine, it appears something like this. It appears as if a lot of bees are aggregated around the bulb. Okay, so this is known as perifollicular lymphocytic infiltrate of alopecia areata. This is important, and this is one very important histological finding which is seen in these patients. If you are ever confused, you can simply do the histology and confirm your diagnosis. Next is treatment. Topically, you can use steroids. Commonly, we use potent steroids like clobetasol. There is role of topical contact irritants. Now you might be wondering how these contact irritants work. Actually, these contact irritants are very potent allergens. Okay, so if over the skin, if you apply them over the affected area, what will happen? The antibodies which are actually targeting the hair follicles now act against these potent allergens and the hair follicles start growing. Okay, so this is the mechanism of action of contact irritants. Commonly used contact irritants are squaric acid, dibutyl ether, dinitrochlorobenzene. These are examples of contact irritants. If the patient is having only a single lesion, you can simply give intralesional steroids. Intralesional steroid which is commonly used is triamcinolone. 10 mg per ml is sufficient for a single patch. Okay, so triamcinolone, that is a long acting steroid, is generally given for intralesional injections if there are few lesions. But if there are multiple lesions and they are progressively increasing, then systemic steroids are used. Commonly used systemic steroids is betamethasone. Now we all know that if we keep on giving betamethasone daily, patient will develop steroid related side effects. So that's why this is given in the form of oral mini pulse. What does that mean? This is oral steroid, mini in small dose, pulse. Pulse means not regularly, only 2 days a week. So what happens when we give 2 days a week? There is a gap of 5 days. Okay, so the side effects are less. Other systemic agents can also be used other than steroids. You can use levamisole. Levamisole is anti-helminthic drug. So why we are using it here? Because it is immunomodulator. Other immunosuppressive drug like azathioprine can be used. After systemic, next is phototherapy. Phototherapy is generally advised for generalized cases of alopecia areata. Generalized means if larger areas are involved, like in patients suffering from alopecia totalis, where there is complete scalp involvement, or alopecia universalis, where there is whole body involvement. So in these patients, alopecia totalis, alopecia universalis, whole scalp involvement is seen. In universalis, whole body involvement is seen. So in such cases, you can use phototherapy. Now remember two terms. One is known as ophiasis and other one is known as cis-IFO. Both these are the patterns of alopecia totalis. That is, when alopecia totalis occurs, that is complete scalp involvement, what happens? It might start from the periphery and then involve the central portion. That is, the hair loss starts from the periphery and then later on the central portion is involved, or it can happen the other way around. That is, the central portion is involved first and then the periphery is involved. Okay, so if the periphery is involved first, it is known as ophiasis. If the periphery is involved last, it is known as cis-IFO. This will become more clear with the help of this image. So in this first patient, you can see that hair loss has occurred from the periphery, but the central portion is spared. This is ophiasis. And if the central portion is involved first and the periphery is involved later, this is known as cis-IFO. Okay, so these are two patterns of alopecia totalis. And if you do not treat these patients, it can further progress and involve the whole scalp. That is known as alopecia totalis. Okay, so sometimes these terms are used in the options. So just remember ophiasis and cis-IFO. If you forget, you can very easily recall ophiasis. And opposite is cis-IFO. So see, ophiasis reverse cis-IFO. Okay, so it is so simple to remember. You don't need to remember both. Just remember first and the second is reverse of it. Ophiasis, cis-IFO. Okay. Now ophiasis starts with O. And how you make O? Like this. That is, you draw a line at periphery. Okay, so ophiasis starts with O. Starts with periphery. Cis-IFO ends with O. It ends with periphery. So periphery is involved last in cis-IFO, periphery is involved first in ophiasis. So it is so simple to remember. Ophiasis starts with O, starts with periphery. Cis-IFO ends with O, it ends with periphery. Okay. So this completes hair and hair disorder. Now we are going to write down few important facts here, where sometimes questions are asked. Like sometimes they might ask you about trichotillomania. Now you might have read about trichotillomania in psychiatry because this is a psychiatric condition. Okay, the patient is obsessed with tendency to pull his own hair follicles. Okay, so patient keep on pulling his own hair follicles, and due to which sometimes these patients present with a patch of hair loss. Okay, so there might be a patch of hair loss in these patients as well. Okay, but remember that this is not due to some hair disorder or some skin disorder. It is due to pulling of the hair follicles. Okay, so remember, if such patient comes to you, so how you are going to identify? So how these patients clinically present? So clinically you will get a patch of broken hair follicles a patch of broken hair follicles in bracket variable length. So this is very important. So you will find a patch of hair loss. There will be a site from where the hair loss has occurred, and in that area, in that patch, variable length of broken hair follicles are present. Okay, so what happens when the patient pull the hair follicles? They break, but they do not evenly break. They break at various lengths. So if you find variable length of broken hair follicles, then you should suspect trichotillomania. Okay, and obviously if the patient have some psychiatric illness, or patient is like, commonly these are female patient, because you might have seen hysteria patients, they are also female patients commonly. Okay, so these patients, they are very anxious personality, and they have this tendency to pull their own hair follicles. Okay, now if you want to confirm your diagnosis, you can do two things. First is skin window test. See, this is no longer done. This is an obsolete old test, but this can be used to differentiate from other conditions. Like if this is a patch from where the patient is pulling the hair follicles, what you can do, you can select one small area in this patch and shave all the hair follicles. Okay, then ask the patient to come back after a few weeks. Let's say after 2 weeks patient comes back, you will find in this patch which you have shaved, all the hair follicles are normally growing. There is no hair loss in this patch, but in the surrounding area there is still hair loss. Why? Because in the area which you have shaved, the hair follicles are so short that patient cannot pull them. Okay, while in the surrounding area the hair follicles are long, so here still the patient is pulling the hair follicles. Okay, so this can be used to differentiate this condition. Another thing which you can do is simply you can do histology. On histology, you won't get any inflammation. Okay, so unlike alopecia areata where there is a lot of lymphocytic infiltrate, here no inflammatory cells are present. Second, because the patient is pulling the hair follicles, you might find perifollicular hemorrhage or hematoma. So perifollicular hemorrhage or hematoma might be present, and trichomalacia. Trichomalacia might be present. These are, what are trichomalacia? These are incompletely keratinized hair follicle. Okay, so such incompletely keratinized soft hair follicles might be present on histology. So these are the features which can be used to differentiate them with other conditions, and the treatment of choice for this condition is behavior therapy. So behavior therapy is the treatment of choice. In the important facts, you can write down one more condition, that is pseudopelade of Borok. So pseudopelade of Borok. First of all, remember that this is a very rare condition. In this condition, scarring alopecia occurs. Just now I will be discussing various conditions which cause scarring and non-scarring alopecia. This is example of scarring alopecia. So in this condition, scarring alopecia occurs. These patches of scarring alopecia which develop in pseudopelade of Borok, they are so arranged that they give a pattern, and that pattern is known as footprint in the snow. So footprint in the snow pattern is seen in, this was the question which was once asked in DNB. So footprint in the snow pattern is seen in pseudopelade of Borok. What does that mean? See, let us consider that there is a patch of scarring alopecia. This is one patch of scarring alopecia, and in this type what happens, another patch develops on the other side, then one patch develops here, then another patch here, then one patch here, then another patch here. So if you see the pattern, you will find that there are patches which are present in such a way as if there is snow over the floor, and let's say you are walking over it. Okay, so what you will leave behind? You will leave behind your footprints, one on this side, another on this side, one on this side, another on this side, one on this side, another on this side. So such patch is seen. Okay, so this is the footprint in the snow pattern which is seen in pseudopelade of Borok. Now whenever you will read alopecia in any book or guide, you will find two long lists. One list of conditions causing scarring alopecia, another list of disorders causing non-scarring alopecia. They are also known as cicastaceal and non-cicastaceal alopecia. So scarring or cicastaceal alopecia, non-scarring and non-cicastaceal alopecia. Okay. Now because there are two long lists, you need to remember them, and many a times we forget them. Okay. So instead of memorizing both the list, you can just memorize one complete list and exclude the other one out. Okay, so let us remember one list, and that list is very simple to remember because I'm going to give you few mnemonics here. Okay, so let us remember non-scarring alopecia. It can be of two types, primary and secondary. Now, primary non-scarring alopecia occur in all those alopecias which start with these two alphabets, that is A and T. So, such a simple mnemonic. All alopecia which start with alphabet A and T cause primary non-scarring type of alopecia. Okay, let us see. Today we have discussed so many disorders and most of them were starting with alphabet A and T, like anagen effluvium, telogen effluvium, alopecia areata, androgenetic alopecia, trichotillomania, tractional alopecia. So tractional alopecia, here what happens, there are few hair follicles which are under constant traction, like due to some weird hairstyle, there are few hair follicles which are always under constant traction. So what happens, they start losing off. That is known as tractional alopecia, and that is the reason why this is also known as hairstyle alopecia. This is due to weird type of hairstyles. Then secondary non-scarring are those hair loss which occurs due to some secondary condition or some skin disorder, like due to SLE, like thyroid disorders, both hypo and hyperthyroidism. Then hypopituitarism. Then certain deficiencies like deficiency of zinc, iron, biotin. So you can see how simple it is to remember. All alopecia which start with alphabet A and T cause primary non-scarring type of alopecia. Then thyroid disorders, hypothyroidism, SLE, hypopituitarism, and deficiency of zinc, iron, and biotin. Okay, so if you want to remember all these causes, you can take the help of another mnemonic, that is Tata Sky HD. Tata means all 80. So all these 80. Along with this T also, that is both hypo and hypothyroidism. Then S for SLE. Then H is for hypopituitarism. D is for deficiency. Along with SLE, you can remember one more S, that is secondary syphilis. In secondary syphilis, there is one specific type of alopecia, that is moth-eaten alopecia. That is also example of. So with this S, you can remember two things, SLE and secondary syphilis. This is also example of non-scarring secondary alopecia. We are writing important facts here. You can remember one more point. Deficiency of zinc can lead to non-scarring type of alopecia, and it can also lead to one important condition which is known as acrodermatitis enteropathica. Acrodermatitis enteropathica. Okay, if you want to remember this condition, this is so simple to remember. Acro means acral parts like hand, feet. Along with this, face is also involved, especially perioral area, and groin is also involved, perianal or diaper area. So these areas are commonly involved, and what you will get over these areas, dermatitis. So the lesion are erythematous, inflamed, might be scaly, and enteropathica, because intestine is also involved, because these patients suffer from diarrhea, and non-scarring type of alopecia. All these features might be present. Okay, so if you find a child suffering from diarrhea with erythematous scaly lesions over hand, feet, perioral and diaper areas, then suspect acrodermatitis enteropathica, which is due to zinc deficiency. And how you will treat it? You will treat it with zinc supplement. They are to be given daily and many a times lifelong. Okay, so here you can see this is a patient suffering from trichotillomania. Again, you will find a patch of hair loss, and you will have to take the history, and patient attendant might tell you that patient keep on pulling the hair follicle from that area, and when you examine, you will find variable length of broken hair follicles. So within the patch, you will find variable length of broken hair follicles. This is a patient suffering from secondary syphilis, where this non-scarring type of alopecia is seen. This specifically is known as moth-eaten type of alopecia. Then scarring alopecia, I told you this can be of two types, scarring and non-scarring. Okay, so scarring alopecia generally is the permanent type of hair loss. This is permanent type of hair loss where the hair follicles are destroyed, their hair roots are destroyed, and that's why the hair follicles do not come up. Okay, so this is a permanent type of hair loss, hair fall, or sequestration alopecia. This generally develop like if in this patient there was history of folliculitis. Okay, so where folliculitis occurred, there the hair roots were destroyed, and then these patches are seen, these patches of hair loss where there is permanent hair loss. Then DLE, that is discoid lupus erythematosus. Now remember one point, I told you SLE. SLE presents with non-scarring alopecia, but late in the disease it might become scarring. While DLE, discoid lupus erythematosus, always presents with scarring alopecia. So this is one important point to remember, that SLE, systemic lupus erythematosus, non-scarring alopecia, but late in the disease it might become scarring, and in DLE always scarring alopecia. Now sometimes questions are asked on DLE, so you can write down few points, important points which you can remember about DLE. So DLE, one you already know, that is it presents with scarring alopecia. Second, occurs commonly over sun exposed sites. Hypopigmented lesion with hyperpigmented margins. These lesions are generally scaly, so scaly lesions. If you remove the scales, you will find follicular prominences on the underside of the scales. This is known as carpet tuck sign. And there is role of hydroxychloroquine in the treatment. Okay, so these are 5 important points which you need to remember about DLE. This is a patient suffering from DLE where you can see that over sun exposed sites like scalp, face, these lesions are present. The central part of the lesion is hypopigmented or light in color, and the surrounding area is slightly dark in color. Like here also you can see this is the light color area and the surrounding area is dark. Okay, so in DLE patient, this hypopigmented lesion surrounded by hyperpigmented margin is seen, and these are scaly lesions. And if you take the forceps and remove these scales and look at the under surface of the scales, you will find follicular prominences. So this is known as carpet tuck sign. Why it is known as carpet tuck sign? Because let's say there is carpet over the floor, and what we do, we tack it with the nails so that it do not move. So we take it with the nails. Okay, so if you try to remove this carpet, you will find prominences of the nails on the under surface. So this is known as carpet tuck sign, and there is role of chloroquine, hydroxychloroquine in the treatment, and this generally occurs over sun exposed areas, and when it occurs over scalp, it might lead to scarring hair loss, sequestration, or permanent type of hair loss. Okay, so these are the points which you need to remember. If you forget this, you can very easily remember we are discussing what? Discoid. And in discoid lupus erythematosus, third alphabet is S. So you need to remember 3 S. First is scarring alopecia, sun exposure, scaly lesion. You can also remember 2 C, that is carpet tuck sign and chloroquine. Okay. Here you can see this is a patient suffering from acrodermatitis enteropathica. I told you acrodermatitis, here hand, feet, perioral area, diaper areas are involved. So you can see here around the mouth of the patient, these erythematous lesions are present. Okay, face involvement is there, and enteropathica, these patient might develop diarrhea as well. So if you find such patient, then you should suspect acrodermatitis enteropathica, and the treatment is zinc supplement.